We're going to move to the next portion of our program, which is case studies. And these are really informative for patients to be able to see how do the doctors actually monitor our cases, and if there's a tumor board, how do they proceed through the case. So we're going to start with a mid-gut GI case, and Dr. Auerbach from UCLA is going to present that one.
So all our PRT patients are exceptional, but I will show you an average patient. This was a 47-year-old female who had been diagnosed with an ileal carcinoid back in 2006. The Ki-67, which is our marker for the grade of the carcinoid, ranged from 3 to 20%, so it was a G2 tumor in terms of grade. She did undergo local surgery that same year, and then was diagnosed with metastatic disease to her liver in 2009. And then through the next several years, she had multiple treatments, including surgery, radio frequency ablation, alcohol ablation, and she also received monthly sandostatin therapy. Oh, so it doesn't work, okay. From 2009 to 2014, she had multiple treatments, directed treatments to the liver, including surgery, radiofrequency ablation, and alcohol ablation, and then also as a systemic therapy, monthly sandostatin injections. Then in 2015 and 2016, disease had progressed. As part of a clinical trial, she was started on pazopanib, a tyrosine kinase inhibitor, but that medication had to be stopped due to severe toxicity. And then the patient herself had actually heard about the expanded access protocol for PRRT that we had started at UCLA, and herself contacted us regarding the possibility of being enrolled in the study. So she put us together with her treating oncologist, and we gathered all the information that she had, all the diagnostic information that had been acquired over the years, had her come to UCLA, and then went over everything with her and deemed her acceptable for the expanded access protocol. And then as part of the consult, we explain to our patients, once they are deemed acceptable for the expanded access protocol, we go over the treatment, what it entails. It's 4 cycles that are given 8 weeks apart. It starts with pre-medication to avoid nausea, which is induced by the amino acid infusion that we give to protect the kidneys. After the anti-nausea medications, patients receive the amino acid infusion, which keeps on running during the day. And then 30 minutes after the amino acid infusion is started, we give the actual drug called Lutathera, which is the dotatate linked up with the Lutetium 177. That infusion takes roughly 30 minutes, and then the amino acid infusion is continued to complete 2 liters of total fluid. So patients, depending on how well they tolerate the amino acid infusion, spend roughly between 4 and 8 hours in our department. But at the end of the infusion, they're able to go home and continue with their life. So back to this patient, the first thing we did is we went over the imaging that she had, and this is still an octreotide scan, which is really outdated now that we have dotatate approved. But the octreotide scan just doesn't have the same resolution and sensitivity. What you can see here, this is what's an anterior image looking at the patient from the front. This is looking at the patient from the back. You see uptake in normal organs, mostly the kidneys here, and then excreted tracer here in the bladder. This organ here is the liver, and you can see all these dots in here, these what we call hot spots. This is where the tumor sits, and you can see it better here on the axial images. This is the front of the patient, this is the back of the patient. This is the right side, this is the left side, this here is the liver, These here are the kidneys. And you can see all these hot spots here in the region of the liver. This is where the patient's metastatic disease sits. It takes up a lot of the tracer, telling us that there is a high density of somatostatin receptors. Since the PRT targets the same receptors, we know that this is a good candidate. This patient is a good candidate for PRT. So we set up scheduled the first cycle of PRT for the patient, which was given in October 2016. And then every 8 weeks, she got an additional cycle for a total of 4 cycles. The patient tolerated the therapy without any significant side effects. Most significant side effects really occur during the amino acid infusion, which causes mostly nausea. We've now given over 40 treatment cycles to a total of 19 patients. We have a pretty good handle on the nausea with the appropriate antiemetic or anti-nausea medication that we give, and also by titrating the rate of the infusion, of the amino acid infusion for patients. So most of our patients are comfortable and don't experience any significant nausea while they're getting the treatment. This patient then got some imaging done after the second cycle, and it showed stable disease to slightly improved disease. And these are images here. So the first set of images that I show you here are what's called post-therapy lutetium dotatate images. If you remember, the Lutathera that we give for the treatment not only treats the tumor, it also emits photons that allow us to take a picture. And after we give patients their treatment infusion, we like to take a picture to see visually that our treatment is going where we want it to go. And that's what you can see here. This is an anterior image, and you see the liver, and you see all these hot spots. So the treatment is going where we want it to do. And this is just to confirm it here on an axial slice. Again, this is the treatment going where it's supposed to go. Then we did the same thing after the third cycle. These images done with the Lutathera are not good enough really to assess treatment response. So that's really the domain of either PET-CT or anatomical imaging with CT, dedicated CT or MRI. So here on this patient we have a baseline CT scan, and then we have a subsequent MRI that was done after the second cycle of PRT. And I told you I was going to show you an average patient in terms of response. So this patient had what we call stable disease. There were a couple of lesions that had actually gotten smaller, such as this one here, where you can see the initial diameter of this lesion was 47 millimeters. On this scan done after 2 cycles, the lesion had shrunk to 27 millimeters. But the overall disease burden had remained stable. And if you look at the results from the NETA-1 trial, what we really want to achieve and what we can achieve with PRT is not cure, or in most patients what we achieve is a stabilization of the disease, increasing the progression-free survival, the time it takes for the disease to get worse, and increasing overall survival. That said, there are patients, and one of them is actually here today, where you see amazing responses. There's about 1/5 of patients where disease actually gets smaller or sometimes even completely disappears. So this patient is scheduled to get follow-up scanning after her 4th cycle, and hopefully things will remain stable or have further improved compared to the prior imaging. Thank you.